My city, Temuco, in Chilean Patagonia. It has the national parks, volcanoes, and lakes. It's a great tourist place for visitors. My kids, we need to start today in a difference between the classic orthodontic and the pre-surgical orthodontic, because the classic orthodontic is in one way and the pre-surgery orthodontic is in another way. What? Why? Because the classic orthodontic obtain the total goals only with braces, but when we prepare a case to surgery, we obtain the total goals with the surgery in the operating room. What are our goals? Facial balance, the dental aesthetic, functional occlusion, temporomandibular joint, periodontal health, airway space, and stability in a long time. When we receive the patient, our first decision is this patient an orthodontic treatment, or is this patient an orthodontic and surgery treatment? Is our first decision. Then the second decision is the patient is with extraction or without extraction. Remember the indication to the extraction. First, the model discrepancy, the crowding, and then the incisor inclination to the basal plane in encephalometric discrepancy. Both are the total discrepancy. Okay, what happened with the orthodontic preparation? What are the keys? The keys in orthodontic surgery treatment are, first, the cephalometric point. We put the incisor in a correct inclination on a basal plane. The second point, the aesthetical point. You need to analyze the nasolabial angle and the profile in projection to the two vertical line. The third point, the occlusal point. Check the model in class 1. It's to obtain the match before the surgery. The first point, the incisor inclination in upper incisor and lower incisor. The lower incisor on a basal plane is 90 degrees, and the upper incisor on a basal plane, a B-spinal plane, is 70 degrees. What happens when you put the incisor in a correct inclination? You can obtain, first, the dental overjet equal to the skeletal overjet. In this way, the skeletal movements in your surgical planing will do the necessary change in a soft tissue to obtain a facial balance. It's very important because you need, before the surgery, the same situation in the bones, the same difference in the bones and in the mouth. Check this case, please, with me. She is a skeletal class 2. She needed the lower extraction. Her face is a class 2, but her mouth has edge to edge and level a little class 2. The occlusal view, the X-rays pre-treatment, and if we check the lower incisor inclination is 110 degrees. It's too much. We need to move back the incisor and clear the case before the surgery. We remove the lower first bicuspid in this case and create the necessary dental overjet. Close the spaces with the MBT system 2 to move back the incisor, the lower incisor. And this is the situation before the surgery. She has class 2 in her face and in her mouth. If we check the skeletal problem, it's the same to the dental problem. Okay, it's the same difference to the maxilla and jaw, and the lower incisor and upper incisor. The pre-surgical analysis, and the surgical planning. Now, before the surgery, our lower incisor inclination, it was okay, 93 degrees, close to the average. Immediately post-op, her new face and her new occlusion, very different than before. Close to the end, remove first the lower braces and then the upper braces. At the end, profile front and smile front, and her mouth in class 1. The occlusal view, the functional occlusion. Remember our goals, the functional occlusion is one of them. Before the treatment, before the surgery, and at the end. 5 years post-op, post-treatment. Remember the last goals is stability in a long time. Okay, the second point in the preparation to the surgery is analyze the aesthetical in a patient. The nasal angle is one of them. The average is 105 degrees. Why is more important? Because in orthodontic preparation treatment, when you do the extraction in a patient and the bottom nasolabial angle finishes open, it is definitive. Because it's very difficult to change it in the surgery, included with the level 1 multi-segment. We will check this case. She is a skeletal class 3. Her nasolabial angle is very good. It's so close, but it's good. I need to maintain it. Her mouth is obviously class 3 with the spaces in the upper arch. We use these spaces to move back the incisor without extraction in a correct preparation to the surgery. Why? Because our nasolabial angle was critical. The upper inclination is close, 55, the average is 70 degrees. We move the upper incisor now back and clear the case. The negative overjet appear immediately in the patient. Our situation pre-surgery, the upper incisor inclination is 65 degrees, close to the average, very close to the average. Our situation before the surgery, the exit in orthodontic preparation, it was maintain the nasolabial angle with the same angle, with the same degrees. Pre-surgical analysis and our planning. Immediately post-op, without a spleen, without final spleen, match occlusion, close to the end. At the end, in class 1, midline is on, okay. Check the functional occlusion. The X-ray control, post-op, her new face. We can see the same nasolabial angle before and after treatment, but her face is different. Before and after occlusion. Before and after the airway space, remember one of them, our goals, the airway space, or maintain or increase. but not decrease. Before and after her face. Good. Okay, the second point in an aesthetical factor is the true vertical line. In a facial analysis, in natural head position, it's very important the true vertical line. It is perpendicular to the true horizontal line, and you can obtain a complete information of the face. Why? Because the face in our patients determines how you treat the occlusion. We will check this case. He's man, he's a skeletal class 3 with lateral mentonyms, but he had a problem. His face is like a class 2, with the chin, it was back. But his mouth is a class 3 with edge to edge and lateral mentonyms. The true vertical line show us the facial class 2, but the occlusal exam, we can see the occlusal class 3. What should be our goal? What happened? It's the face more important, or it's the occlusal goal more important? The facial balance or the malocclusion? The face determines how you treat the occlusion. This is the great statement. His occlusion, the pre-X-rays, his inclination, the lower and upper inclination incisor, there was good, close to the average. Our preparation to the surgery, before the surgery, the alignment, it was complete. Our cephalometric analysis, our surgical training, move maxilla and jaw forward, a little genioplastic. Immediately post-op with elastic, full day for 2 weeks. Remove the elastic, close to the end. Remove the braces. The occlusion is very good. In class 1, Minda is on. Check the functional occlusion again. Good. His new face is a class 1. And the occlusion, it's the same, class 1. Why? Because the face determines how do you treat the occlusion. Before and after. Before and after. The third factor to analyze before the surgical treatment. Check the model in class 1, check the correct overjet and overbite, the models in class 1 and midline on. Why? Because you need to obtain more stability before the surgery. And then surgery, this stability is the same stability to the bone and to the temporomandibular joint. With braces, the same. Check the model in class 1, it was okay. When you check the model in class 1, you can see the occlusal stability. You can obtain the skeletal stability post-op. It's very good for the stable case. Check this patient. It's a skeletal class 3 with a great open bite. The mid-face, it was back. It's a special case. Look at the occlusal view. It's a great open bite, bilateral cross bite, class 3 bilateral. It's a typical patient class 3. Check his upper arch. It's a small upper arch. The lower arch is very big. He had a special case because in another treatment, he ended this treatment with an incisor root resorption. We need to prepare this patient in a different form. We prepare this patient in a segment, the lateral segment, right and left, and the anterior segment. Now with a continuous arch because he had root resorption in an anterior teeth. We maintain this step before the surgery. Put the arch and maintain the difference step, the anterior and right and left sides. Before the surgery, check the temporomandibular joint. Before the surgery, our prelim move maxilla 7.1 millimeters, move down 2.1 millimeters, great counterclockwise movements to the jaw and center. But the really great change, it was in a model. Because when we analyzed the models, we need a great expansion into the surgery. We need, in canine, 4 millimeters to expansion. In upper first bicuspid, 5.5 millimeters. In second upper second bicuspid, 7.5 millimeters. In a first molar, 9.5 millimeters. And in a second upper molar, 11.5 millimeters. It's a great expansion. We need too much in the models and too much in the occlusal post-op to maintain this expansion. Immediately post-op, close to the end, realignment the braces, remove the upper braces first, and then lower braces. Look at the difference in upper arch. It's a big upper arch. Check our occlusion in functional movements. Check final temporomandibular joint position. The X-rays control. And we can compare before and after our new arch form in our upper arch. Finally, we expansion 3 millimeters in a canine, 5 millimeters in a upper third bicuspid, 7 millimeters in second upper bicuspid, in a first molar 11 millimeters, and in a second molar 12 millimeters. It's a great expansion. We need much in the models. Her new face, his profile, his three-quarter view, before and after, before treatment, after surgical and orthodontic treatment. Close the open bite without cross bite, bilateral cross bite, the right side, left side. Before the treatment, the form of the arch is very different, and after treatment. The lower arch, it was the same. 5 years post-op. He's stable. He's very stable. He's a handsome man. 10 years post-op. Please check the occlusal view. It's the same. It's the same, very stable case. 10 years post-op with expansion in a surgery that 12 millimeters. But we have the special cases in orthodontic and surgical treatment. Patient in grow. Patient in grow needed the first phase when in grow, maybe a dental phase, and then when finished his grow, we can do the final treatment with a surgery. Patient in grow can be treated with a orthopedic traction in early periods and extraction when their discrepancy is severe. In these cases, you can only treat the dental problem in a first phase, not the occlusal problem or the skeletal problem. The occlusal and skeletal problem will be treated without growth in orthodontic and surgical treatment in a second phase. This patient is a class 3 patient. He was 11 years old. His occlusal view, a crossbite, anterior crossbite, small upper arch, and he had a problem, a big problem in his canine. We need to put the canine in an arch in a first phase. We need to obtain a space. How? We remove the first bicuspid and traction the canine and put the canine into the arch. This is the first phase treatment in a mixed dentition. We remove the first bicuspid. The right canine appears in the arch. The left canine is very close. Maybe 1 year, no more, 1.5 years is the limit in this phase. Remove the braces. You can see the same situation to the when he starts, because he has a great problem in his mouth. It's a skeletal problem. Now he has 17 years old. He had a break, maybe 5 or 4 years. And then we began the second phase, the final phase. You can see the same situation in the skeletal and occlusal view, but he has the canine into the upper arch. Our inclination. We removed the second bicuspid, lower second bicuspid, because he had a severe crowding in a lower arch in preparation to the surgery. Close the spaces. Okay, he has 18 years old. Now, he was okay to the surgery without growth. Before the surgery, our planing and our incisor inclination, 72, the upper incisor good, 86, lower incisor close to the average, good. Our surgical planing, move great movements in maxilla forward, increase the airway space, immediately post-op, final results in our patient. The occlusal view, final result with the first phase in 11 years, and then a break, and then continues in a 70 years old with the second and final phase. X-rays control. the functional occlusion in our patient. Final result, his face and his mouth. First phase, during the break, in the middle, during the break, and the final result, his face and his mouth. Summary. Okay, put incisors in correct inclination to the bone, and in this form you can obtain very good facial results. Second, check the nasolabial angle and the profile projection to the true vertical line, and decide how to treat the occlusion. The match model in class 1 permits occlusal and temporomandibular joint stable results. And you must do the surgery without growth in patient class 3. In class 2, you can do it with some growth. Thanks for your attention.
Thank you very much, Dr. Messen. Those are some beautiful cases. I'm sure you're very proud of them. This is a certificate. Does anybody have any questions? Okay, then I have one. All right. Since you practice both TMJ and orthodontics, do you find an increased amount of TMJ syndrome post-op in patients that do serial extraction?
Can you repeat the question, please?
Okay. Do you find an increased amount of TMJ syndrome in adults that have had serial extraction for orthodontics? Serial extraction is for premolars?
Yes.
Okay.
Yes.
So do you find an increased amount of that?
But what happened with the temporomandibular joint?
Do you find an increased amount of TMJ syndrome in those patients?
Yeah, okay. You asked me about the preparation to the temporomandibular joint,
Right.
right? Okay. When you have the temporomandibular joint disorder, you have two options. If the patient has temporomandibular joint disorder chronic or it's not chronic. It is not chronic, you need to prepare with aspirin and drugs, pills, in order to stable this temporomandibular joint before the orthodontic treatment, before the surgery. If the patient had a chronic disorder, maybe the chronic disorder won't stable with the surgery because the patient want a good, stable occlusal system with the surgery. Without surgery, for example, with an open bite, with one contact on the molar, it's unstable occlusion to the temporomandibular